Hello, everyone, and welcome to a brand new episode of the Project Umoja podcast, the Pan-Africanist podcast dedicated to uniting and empowering the global African community. Thank you for joining us today. My name is Maurice Gwakum, and I will be the host of today's episode. We are very excited to share this brand new episode of the Project Umoja podcast with Dr. Ngwakum Akisa.
Of Africa for the Africans.
Je ne vois pas pourquoi nous ne chercherions pas ce qui nous unit au lieu de chercher ce qui nous divise.
La lutte continua.
What is needed? Togetherness. Unity.
Dr. Paul Ngwakum is the Regional Health Advisor for UNICEF, the United Nations Children Fund, in Eastern and Southern Africa, responsible for 21 countries under his current mandate. Dr. Ngwakum is responsible for technical and strategic guidance of UNICEF offices in Eastern and Southern Africa, providing support to governments in coordination with partners for situational analysis, planning, implementation, and monitoring of key health interventions with a focus on health system strengthening. Before joining the regional office, Dr. Ngwakum was UNICEF Chief of Health and Nutrition for Zimbabwe and Zambia. He also served as Chief of Child Survival and Development for UNICEF Madagascar. Previously, Dr. Ngwakum worked for UNICEF on immunization, maternal and child health, as well as nutrition in South Sudan, Angola, and Mozambique. Before joining UNICEF, Dr. Ngwakum worked for 2 years as a hospital doctor in his home country of Cameroon. He also has 8 years of work experience with Doctors Without Borders, otherwise known as Médecins Sans Frontières, in different capacities responding to health emergencies in Rwanda, the Gambia, Burkina Faso, Chad, Haiti, and as a medical coordinator in Mali. Dr. Ngwakum is a medical doctor from the University of Yaoundé, Cameroon. He holds a master's degree in public health from the Institute of Tropical Medicine in Antwerp, Belgium, and a certificate in healthcare financing from the London School of Hygiene and Tropical Medicine in the United Kingdom. He speaks English, French, Portuguese, Pidgin English, and one of the many languages found in Cameroon's grassfield regions. And I have to say, beyond introducing our incredible guest today, when we started this podcast, one of the goals, beyond bringing forward a range of different subject matter experts to speak on the challenges, the development challenges faced by the African continent and its diaspora, and seek to find solutions to these challenges, one of the key things that we're hoping to do is documenting some of the bright minds of our generation, and having those archives for the generations to come. And as we know, a lot of our culture is very oral, so the podcast is a great opportunity to do so. And I think beyond, speaking to Dr. Ngwakum's, professional background and his professional track record, I have to say today that this is a particularly special interview. I am interviewing my father. So I will try and stay in the straight and correct, and refer to him as Dr. Ngwakum. But if I do end up referring to him as my father throughout the interview, just know that it is a term of endearment, and I'm doing my best to focus on some of the work that he's done professionally and giving him the space to speak to his expertise and to where Africa needs to go when it comes to strengthening our healthcare systems and providing better services to African citizens, broadly speaking. So, without further ado, Dr. Ngwakum, it really is a pleasure to have you here today. Beyond your thorough bio and some of the more intimate questions that we might be asking you throughout this interview, maybe you can tell us something, not only to me but to our guests and our listeners. Tell us something about you that isn't in your bio and that people wouldn't necessarily expect when they hear about you.
Thank you very much, Maurice, for inviting me to this platform to be able to share with the public some few ideas. I want, first of all, to commend you and your team for the work that you are doing through this platform, discussing issues linked to African politics and the need for unity to ensure availability of basic social services on the continent. I think you summarized very well my bio. As a young doctor, I was determined to bring smiles on the faces of my patients, consulting children suffering from malaria, pneumonia, diarrhea, and even malnutrition, and helping women deliver their babies, and sometimes through surgery. I soon realized all the drugs I prescribed, the surgical operations I did, could not solve the problems of a large number of the women and children in the communities I was serving. Challenges were linked to availability of supplies, stockouts, insufficient and poorly trained and distributed staff, and even decisions to prevent disease outbreaks, doing mass campaigns were things that troubled me. These are things I couldn't really understand. The turning point was when I was posted to Chad in a district where they had had a meningitis outbreak. For information, meningitis is a bacterial infection that infects the spinal cord and can lead to death. And this district had suffered from an outbreak 3 years before and benefited from mass vaccination campaign. Vaccination against meningitis is effective for 3 years. So when I got this information on arrival, I immediately wrote to my management and asking them for vaccines to be able to make sure that I don't come back with another outbreak. But the reply I got was, you need to monitor and prove there is an outbreak. I did my job. I monitored as instructed. And of course, there was an outbreak with dozens of children who died before these vaccines were released by the international group that was responsible for managing stockpiles.
I will actually ask.
Yeah, go ahead.
Yes, I'll stop you right there and ask. I think it's interesting that your first reference point is dealing with some of the challenging diseases and epidemics that we have on the continent. Meningitis being one of them. And I think it will be very interesting for our listeners to kind of hear you speak to your exposure to the healthcare system at various levels, right? As a field doctor, as someone doing monitoring and evaluations for diseases and outbreaks, as someone doing planning and so on and so forth. And I'm really interested for you to speak to more of that, because I think within the right context for listeners that don't have a healthcare background, it can be very interesting to really understand these challenges that we face that are real breaks to our development. But before we really get into some of those technicalities, I'm actually hoping that you can first share something with us that is, that has nothing to do with your professional, with your profession necessarily, that we wouldn't necessarily hear. And then secondly, let us know, when you were young, this podcast in particular is distributed on African Heroes magazine's platforms, right? And so in the spirit of African Heroes, we'd like to know if you could only choose two, one historical and one contemporary, who are your own African heroes, right? So one, start by letting us know like something about you that, our audience wouldn't know at all. And then who were your African heroes? Who are your African heroes as you see them today?
Yeah, thank you very much, Maurice. I'm going to come to who are my heroes, but I think I just want to complete the storyline to finish based on this issue which I was confronted with, not being able to influence decisions, not being able to vaccinate my community because vaccines were not made available, and I didn't understand why. And it pushed me to decide to drop the stethoscope, actually. And went into public health. And this was to be able to contribute in the discussions and decision-making processes. But I just want to, before I get to who are my heroes, just to state that these challenges, they still exist in Africa. Governments, they need to make the right choices for their populations. And I think the right choice is investing in interventions that are going to bring more dividends, reaching the large portion of the population. So in summary, since you wanted to know something in my bio that people may not have heard, what defines me is my life struggle which is basically to be able to narrow the equity gap and taking the services to the more marginalized populations, who are the poor people, the people who are hard to reach. But these are not only health services, but I think it has to be a combination of basic social services that include water, sanitation, and even education, because all these are determinants that affect outcomes of healthcare delivery. Now, back to your question on who are my heroes. I think as I'm in the health profession, working on public health and trying to kind of influence policies to make sure that we reach as many people as possible. And over the years, and even my motivation of going to med school, I think my main heroes are not one person. I have a group of heroes, and these are the frontline health workers, the community health workers, which maybe we don't even hear about them. And these are the people that go to the hard-to-reach geographical zones. There are people that go to the urban slums and to the conflict-affected areas, supporting populations in Africa during multiple crises, including outbreaks, such as cholera, such as the COVID pandemic. And these are my heroes. And some of them, they even pay with their very lives. They get infected and they even die. And that's why I think up front in this podcast, I want to profit to reiterate what I say almost every day, the importance of governments to invest in these heroes by providing them with the right tools and enabling environment to continue serving the communities.
Well, that's a very interesting perspective, and I hope that throughout this interview we're able to speak to more of those, healthcare professionals that are in the most extreme rural areas of the continent, with poor infrastructure, with sometimes security crises, that are there to provide healthcare services to some of the most vulnerable. So I think throughout your story you'll be able to share your own personal experiences as one of those healthcare providers, and then now in your role as supporting those that are in the most vulnerable regions. So I think the next thing I'd like for you to speak to actually is, let's take a step back. Let's take a step back. We've started with some of the most professional, some of your professional reality and the work that you do. But I'd like for us to take a step back so that our guests can get to know you a little bit better and get to know your journey towards the work that you do today. And let's start with the fact that you were born in rural Anglophone Cameroon, a few years after Cameroon's independence and reunification of its English and French-speaking regions, as we know, to happen in the early 1960s. So for the listeners that don't know, maybe this will give me an opportunity to contextualize a piece of African history, which we try and share with the podcast. But the country of Cameroon, used to be a German colony. At the end of the First World War, when Germany lost its colonies, Cameroon was partitioned into two parts: an English-speaking side that was governed as part of Nigeria for over 40 years, and a French-speaking side that was governed as part of French's colonial structures. And at independence, a portion of these English-speaking regions that used to be part of Nigeria actually decided to reunite with the rest of French-speaking Cameroon, which creates a very unique blend of cultures, even in the African context, as being the only African country with this dual heritage of French and English speakers, but also, very tight traditional and historic ties between the populations that exist in these two regions. So you belong to this English-speaking side of Cameroon, or you were born rather in this English-speaking side of Cameroon, and you belong to all of Cameroon, as I'm sure as you would say. But you were born in Anglophone Cameroon a few years after Cameroon's independence. Can you describe some of your earliest childhood memories and how those memories shaped you, as well as describe Cameroon in the 70s when you were growing up as you remember it?
Thank you very much. I think nobody ever asked me such a question before, and I'll try to be very concise as possible. About my early years, my life started with an accident. When I was very young, I had a third-degree burn on my forearm, on the left arm here. And this took me and my mother to hospital for more than a month, where I got treated. And that is part of the things that led me to the profession in which I am today.
And how did you get the burn, actually? How did you get this burn?
I was too small to remember, but I know I was a little boy struggling to creep, and I was in this charcoal kitchen, and I crept onto the fire, and I couldn't get out, and there was no adult actually with me, and before they came, it was really very bad. But that aside, as I was saying, I was a happy child, and I felt I was loved and taking care of my both parents in every sense of the word. I actually grew up in the village, accompanying my mother to the farm. But at the same time, my father, being a teacher at the time, exposed me to reading of books. Books that were available in his collection. And I thought at the time, I didn't think there was something bigger than my village. The world for me was around my mother's farm, it was around my school, and I never thought there was anything beyond until I grew up. But talking about Cameroon in the 70s, what I remember, it was a very beautiful country. I still remember in my primary school, we used to receive cooked food sometimes. I don't know who contributed the food, but at least it came through the administration to us in our primary school. And this contributed to improve nutrition and keep some kids in my village in school, as parents sometimes were too poor to provide a decent meal cooked with oil, a piece of meat, and a little piece of fish. At the time, I think most basic social services that were provided, even if they were not available to the very hard-to-reach areas, they were free of user fees at the point of delivery. For example, government schools were free or partially free, including university education. University students were even paid stipends, monthly stipends. And when I was in secondary school, students that were academically very good had what they called merit-based incentive that ranged between 9,000 to 13,000 CFA francs, depending on the marks that the student had. I still remember I had very happy teachers. Teachers, they were proud of themselves. I guess they had decent salaries, because I still remember my teachers parking cars, these 504 Peugeots or even the ladder cars, to be able to teach us. I remember hospitals and health facilities had the required supplies. I still remember the smell of detergents. When you get into a hospital, you can smell they're using disinfectants to be able to clean around these dispensaries and hospitals. Mm-hmm. I think at the time, everyone was proud and happy of what they were doing for the country. That is my appreciation of Cameroon, growing up as a child in the 70s and even in the 80s or early 80s.
And so just for our listeners as well, you mentioned a stipend that was provided to students. So the franc CFA, for those who are not familiar, is a currency that's used in Cameroon, as well as in a range of other West and Central African countries that was used around the time of independence and up to today. So just to specify that. And it's interesting that you bring that up as well, Dr. Ngwakum. At the time, the children used to finish their meal and then leave the piece of fish and meat for last, so you start with your meat and then eat your meal after. I don't know if you have those memories still.
Well, I think no child would eat the meat first. You finish your food and you end with the most delicious piece of food that you have, which was the fish or the meat. It's not now that children don't eat. We ate the bones, actually.
Wow. Yeah. So your father was a teacher and a farmer, while your mother was a farmer with no formal contemporary Afro-European education. And I specify it in this way because, I think a lot of our elders that are part of past generations, may not have been exposed to Afro-European educational structures as we know them today on the continent, but still had very rich educations, a very rich understanding of the world that certainly influenced you and influenced the way that you were brought up. The main language in which you communicated with one another was not even in Pidgin, which is largely spoken in Anglophone Cameroon and in Nigeria, but it was instead one of the many traditional languages spoken in the grass fields of Cameroon. And this is more of the more intimate side of things. But because you're my father, I know, for example, my grandmother most of the time, even speaking to her in Pidgin, she would more so speak to us in our vernacular rather than Pidgin English. So tell us about your parents. Given that context, you existing in this, early post-colonial period, this transition between the colonial times and the post-colonial times, and then certainly a transition even in terms of culture, right? Of your exposure to our traditional culture and your exposure to where our contemporary African culture during that crux of history. Tell us about your parents. Given that background and that upbringing, tell us about your parents and the kind of values that this traditional African upbringing, in a sense, instilled in you early on.
Yeah, thank you. That's a very interesting question, actually. And I think before I even get into the depth of your question, I just want to maybe share with our listeners and encourage them to continue ensuring we maintain our African languages. Because I think these are beautiful languages. This is part of our culture, and forgetting our languages and hooking on to English or French or some foreign language is not part of us. And I think was one of the things my parents handed over to us. Jero Mba Maurice. That is simply in Bamunkumbit, our local language. Jero means thank you. So thank you for that. My mom and dad, for what I remember growing up, were decent people. They were my friends. My father was also my class teacher sometimes. And I thought he was my role model. They were both Christians. All my other uncles got second wives or third wives, but my father, because of his Christian values, he remained monogamous. As you said earlier, my mother worked in the fields. She had many farms, and we had always had enough harvest for ourselves and even to be able to sell in the market and get money for school fees or some school needs. My father introduced cassava farming in my village, and he contributed to the large production of gari that was sold in the local market and in around other towns in Cameroon. And in addition to toiling the soil, my father, as you said, was a teacher with a Catholic mission. And this combination gave us everything a child growing in the village could have. Both parents, they taught us how to invest in the soil. And that's why whenever I have the opportunity, I have a backyard garden or even backyard chicken. And my father used to say, the soil is very honest. You cannot plant and harvest the same seed. It always comes out more than what you planted. And being a teacher, my father pushed me to work very hard at a very tender age. He was very passionate about literature, and this gained him the nickname when he was in school. They called him Jim. And this is just a name that came out of one of the novels he read. Jim Hawkins is a character in Treasure Island, and Treasure Island in one of the British novels written by, I think, Robert Louis Stevenson. Mm-hmm. He gave me many books to read, even in primary school. I read the book Chenua Achebe's Things Fall Apart, and I still remember there was
in primary school.
In primary school, a little book also.
Wow.
It was called Robinson Crusoe, and this was a novel by Daniel Defoe, and I read it in primary school. So before going to secondary school, I had read 2 little novels, which I think many of my friends didn't have that opportunity. But maybe to come back to your question and maybe to give you highlights of the values which I think my father and my mother, they transmitted to me, and I guess to my peers or to my other brothers and sisters, my siblings actually. Mm-hmm. Hard work. And I think in everything you do, be it on the farm, be it in school, you have to work hard. The second thing is honesty and humility. Among some of the quotes of my father, I can remember my father repeatedly told us, cut your coat according to your size. And he added, you cannot run ahead of your shadow. And for me, this is simply meant we should be contented with what we have and work hard to improve our status and desist from unnecessary competition that can only bring you sadness when you don't have. Just work hard for it, and you're going to be like your friend or like your other classmate later in life. Another thing I heard from my father repeatedly is that literacy is not education. You can be able to read and write, which is you're literate, but still not educated. And for him, and what he wanted from us, to be able to live in harmony with friends in school and with neighbors. And I think that has helped me in the life I'm living now. As traveling around the world, you have to respect diversity. Mm-hmm. And I think my father told me that at a very early age.
Yeah, so I'd like us to jump onto the next point. That was an important point in your journey. So within English-speaking Cameroon, boarding schools are a particularly distinct and big part of our academic British colonial heritage. You went to one of the oldest, prestigious, and well-known boarding schools in Cameroon in those days, and even still to today. So please share with us how this came to be and how you remember your experiences in boarding school in those days.
Well, thank you, Maurice. This is another important milestone in my life, and I must say this was another accident of my life. I had wished to be able to go to boarding school, but my father had no plans of sending me to this prestigious boarding school because it is a private school, was quite expensive, and I think he thought he didn't have the resources to be able to pay for me and also to be supporting my other siblings. So I actually interviewed to go to a government public secondary school, precisely the bilingual secondary school in Bamenda, which is in the northwest province at the time of Cameroon, and not far from my village. And at the time, there were few government schools. So many children wanted to go to this government bilingual school, and the invigilator decided to transfer me to another school about 200 kilometers from my home. And I was just about 11 years old then. with no relatives in this town, and my father thought that was not going to be the best option for me. And being a teacher within the Catholic mission, he told his parish priest this challenge that he was having. And the priest advised we should go for another interview in Sacred Heart, which is this prestigious boarding school. And at the time, the principal, Brother John Phillips of blessed memory, found I was an intelligent little boy, and he decided to help my father to admit me despite the fact that all admissions were over and closed. And he even gave some financial assistance to make sure that my father could complete and pay the fees on time. And I think this was the best experience of my life in boarding school, where I met friends whom I call today my brothers, and they are scattered all over the globe. And we still collaborate as ex-students. In my class, we're having our WhatsApp group. And in the last 3 years, we've been able to give back to the community by providing scholarships to children in this school based on merit, based on need, and also based on the leadership skills that they have to be able to encourage them to grow up as whole persons, to be able to serve the society. So that is how I found myself into Sacred Heart, and now I'm very proud to be part of this alumni. Yeah.
And I actually want you to speak to a piece of that experience that I think is rather fascinating, and something I learned not very long ago, but also made a lot of sense in the historical context. So, Sacred Heart in Cameroon is one of many other boarding schools, nevertheless one of the oldest. But in those days, not only in the boarding schools, but in the universities as well, and not only in Cameroon, in other African countries as well, we're still coming out of the colonial period. So a lot of these educational institutions are still being governed by the Europeans that put them there to begin with, all right? So I think if you're a student at Sacred Heart today, for example, a lot of your professors and your teachers will be Cameroonians, right? Same thing if you go to the university today, and this is the same thing in any other African country. If you're in Nigeria, if you're in the Congo, if you're in Zambia, if you're in Madagascar, most of your teachers and your professors are coming from the country of origin. However, in those days, it being the 70s, and not too far from independence, you still had this, this clergy, shall I say, of administrators that were still part of this educational system and played a big role in shaping you boys in those days. So what was it like being in Cameroon in that time? What was your experience like at Sacred Heart? I can imagine you also had some Cameroonian teachers as well, but you had British teachers that shaped a lot of your experience early on. Maybe you can speak to that as well, and how you reflect back on that today.
Well, I think that is another very important point to reflect on. All the administration, from the principal to the vice principal to some of the heads of department, they were expatriates actually. Mostly the clergymen, the reverend brothers. But we also had many Cameroonian teachers. The issue was not with the mix of teachers, it was with the syllabus and the content of the teaching. And I think, for example, when we did history, we did European history and all that turned around the world wars. When we did literature, we read lots of Shakespeare's books, and I remember when I traveled to London, I was so proud, or people were so anxious or happy to see I knew so much of their history, talking about Dunsin and Hill, the island of Mull, because those are all the things that we read in literature books, in Macbeth, we read in Julius Caesar, and all these books like Lord of the Flies, written by William Golding and things like that. So most of the things, the material that we used to teach us were kind of from the UK, for this specific case of English-speaking Cameroon. But I think things are changing, or things have changed as things have evolved. There should be more of the things that are locally now. And also at the time, our evaluation was linked to London GCE. Although we wrote Cameroon GCE, but it was kind of, at the time, very much in line with the principles and the quality of the GCE that was set in the UK, actually.
Interesting. Yeah, that's a very interesting perspective. I cannot imagine what that must have been like in those days, especially. But it's you're absolutely right that that mix certainly gave you young boys in those days an exposure to the world that allowed you guys, empowered you guys in how you navigated the world. However, as you stated, it's more so the content of the curriculum that had room for improvement to allow you guys to learn more about your own local experiences. Nevertheless, it did expose you to the world, which allows you to connect with those that belong to other backgrounds and cultures. And one of the things I want us to also speak to, I'd like for you to speak to is, you're actually, and I guess we'll hear this as we continue to go through the podcast, but you're actually one of the most well-traveled Africans, dare I say, people in the world, particularly within the African continent, where you have traveled to almost every country in sub-Saharan Africa. I mean, in your current role, you're responsible for 21 countries in Eastern and Southern Africa that you have to visit for monitoring and planning initiatives. But I think one of the things that's really interesting about this particular time in your history is that, especially at this stage in your career, prior to starting medical school in Yaoundé, Cameroon, in September of 1987, if I'm getting my date right, at the age of 20, about to turn 21, prior to leaving to study medical school in Yaoundé, you had actually never lived outside of English-speaking Cameroon. And this, even for me, this is something I learned, casually in a conversation we were having maybe a few years or a few months back. I never realized this, that your first experience, leaving your home, leaving Anglophone Cameroon and going outside of this sphere was around the age of 20. So I guess my question to you is that with that context, how did you perceive the world around you as you're about to embark on this life-changing journey? How did you perceive Cameroon as this being your first journey to discovering more of your home country and getting exposure to this French-speaking side of Cameroon? And how did you understand your African identity and your identity as a Cameroonian at that stage? What were some of your first few memories? I'm asking you a lot of questions, but I'm sure you're understanding what we're trying to get at is essentially how you experienced all of this change.
Thank you very much. I think there is a lot to unpack in those questions. But I think the first thing I just wanted to share with the audience is nothing good is given on a platter of gold. There were times as I was growing up, I asked myself many questions, and if I will one day become what I dreamed to be as a child. There was only one medical school in Cameroon where admissions were very competitive. 75 new students were admitted out of thousands and thousands that sat for the exams each year. Another thing is, when I was in secondary school, at a certain point, one of my teachers said, if you want to become a rich person, you have to work in the oil industry. And I kind of derailed a little from my initial dream of doing medicine, and I thought I was going to do petrochemical engineering. And in that confusion, I stopped doing physics, which was an important subject to get into med school. So I had to self-teach myself physics while preparing for the entrance exams. But the things that gave me the courage to go on, because number one, I promised my mother I will become a doctor and give back to the community what the hospitals did to me as a child when I had my third degree burn. But something that happened, this was just by chance also, around that same period, someone gave me a book called the power of positive thinking. And if I remember well, the author was Norman Vincent Pearl. And there I learned it makes big difference in your life if you stay positive. I can still remember this phrase I read in the book: a sense of inferiority and inadequacy interferes with the attainment of your hopes. But self-confidence leads to self-realization and successful achievements. And this changed my life completely. And with that self-confidence and the story I read, nothing has ever been the same again. And I did everything to get anything I wanted to get, including making it into med school. Now, part of your question was memories. What do I remember moving from my rural village or my rural areas in Anglophone Cameroon into university in French Cameroon? The first thing I still see, it was too crowded. And at the time, it was the only university in Cameroon, and all roads led to Yaoundé. And coming from a secondary school where we were maybe 50 to 40 per class, to a class with over 1,000 students, you can imagine how overwhelming it was. And after 1 year in the university, in the Faculty of Science, I passed into med school, where I was able to follow classes in French and in English, depending on the background of the teacher. But we were allowed to answer questions during exams in English, the language that we're more comfortable in, and it was left for the teacher to be able to decipher what we wrote and maybe give us the marks that we merited. But there were quite some challenges, I must say. And as we navigated this process, I can remember the only time I did a second session while in med school was in the first year, and it was not my fault. My anatomy teacher...
A second session meaning a repeated semester?
You don't repeat the class. You write exams in June, and people who don't make it, you come back in September to be able to be in the next level in October. So I couldn't make it in June because of a fault, not my fault, my teacher's fault, but I had to come back in September, and this is the story. I picked a question and I opened. It was written, articulation de la hanche. If you translate with the knowledge of French I have today, it means the hip joint. But honestly, that day I couldn't remember what hanche stood for, because I had another appellation of that joint which was linked to the bones. In French they call it articulation coxo-femoral, which is the coxal and the femur, the bones that join this, that are responsible for putting this joint together. And I told my teacher, can you translate for me? And he said, yes. This is because you don't come to class. If you had come to class, you would have known this. And he told me ankle. Hanche and ankle is not the right thing. And I made that mistake, and this pushed me to September. But I think moving beyond that, it has been a great experience to be able to profit and learn French and English. And that's why I can travel the world. I can flip-flop between English-speaking and French-speaking countries to be able to deliver primary health care to communities. What I just want to put out here is that, as I said before, positive thinking leads you to hard work, leads you to believe in yourself, and no challenge is insurmountable. You can always go across challenges. I guess I answered your questions, but you can prop in if there are issues that I omitted, because it was quite
absolutely. I think you did a great job of answering it, and I'm also curious to know that in those days, you know, d'abord, on est au pays, on est au Cameroun, alors on peut parler dans les deux langues. Je ne sais pas si les gens qui vont écouter vont savoir que, bon, on vient de changer au français. Et je sais que dans le contexte du podcast, ce qu'on essaye de faire, c'est on essaye d'avoir des épisodes en anglais et en français. Et ça, c'est à cause du fait qu'on essaye de bâtir des liens entre ce monde anglophone et francophone qui existe sur le continent d'une manière générale. Mais je pense que, étant donné que vous êtes Camerounais et on parle spécifiquement du Cameroun, ça serait intéressant aussi de voir comment vous avez vécu cet échange de culture à cette époque-là. Surtout étant donné que, et on ne va pas continuer tout l'épisode en français, je pense qu'on va continuer la majorité de cet épisode en anglais, mais ce que je tiens à dire, c'est que quelles ont été vos observations à cette époque-là des différences culturelles entre le Cameroun anglophone et le Cameroun francophone, surtout à cette époque-là, et surtout étant donné que tout votre vécu à ce temps-là était dans le contexte anglophone du Cameroun, dans le contexte anglophone de l'Afrique d'une manière générale, l'Afrique de l'Ouest, et ensuite vous voyez immersé, ou immersed, shall I say, dans le monde francophone du Cameroun. Quelles ont été juste des petites observations, peut-être culturelles, que vous avez vues, that surprised you in Francophone Cameroon, if you allow me to be Cameroonian and switch between the two languages.
Mais je pense que je vais faire les premières phrases en français, mais je vais retourner rapidement en anglais parce que je suis plus confortable en anglais, je pense. Mais la première des observations que j'ai eues, c'est que les écoles primaires dans les zones francophones ne portent pas l'uniforme. Alors que pendant mon enfance, l'uniforme était l'identité de l'enfant et c'était une possibilité, un moyen d'identifier un enfant qui est hors de l'école pendant les heures de l'école. On va savoir que cet enfant vient de cette école et immédiatement l'enfant va retourner à l'école. Mais dans une zone où il n'y a pas l'uniforme à l'école primaire, il est un peu difficile de faire la différence entre un enfant qui est à l'école ou un enfant qui n'est pas à l'école pendant les heures de classe. Donc c'était la première des choses qui m'a frappé. Mais à l'école secondaire, je pense qu'il y a l'uniforme, il y avait l'uniforme partout. Mais en dehors de ça, je ne pense pas qu'il y avait une grande différence parce que, en dehors du fait qu'on parlait l'anglais et français, les coutumes de base étaient presque les mêmes. Les gens qui venaient de l'Ouest et les gens qui venaient du Nord-Ouest, on ne peut pas faire la différence par rapport à la culture. Et parfois, les gens qui viennent du littoral et les gens qui viennent du sud-ouest. Et je pense qu'il faut avoir un regard très précis pour pouvoir faire la différence en dehors de la langue. Donc, je pense que cette division entre, on dit, Cameroun anglophone, Cameroun francophone, à la base, en dehors de la langue, au fond, ce sont les mêmes gens.
Parfait. Interesting. So we'll switch back to English. And now we're moving on to some of the more, the more professional aspect of your expertise. And I'm hoping that you can shed some light on this for our audience as well. Within your process of becoming a doctor in Cameroon or in Africa, more broadly speaking, I think through this journey that you share with us, we can actually learn a lot about some of the gaps that exist in our healthcare systems and some of the challenges that you experienced as a professional being trained through this system to ultimately serve the most vulnerable Africans out there. So, for example, you mentioned, this is something I heard as you were speaking, was that at the time, only 75 students a year were admitted to medical school, meaning that, and not every student will necessarily graduate. So that entry class of 75 students might not actually graduate up to 75 doctors in a graduating class. And to speak to, around less than 75 doctors being graduated every year nationally to go and serve a rapidly growing population, that is certainly a challenge that I'm sure you'll be able to speak to. One of the things I was reading in preparation for this interview was, just the doctor-to-patient ratio in Africa is quite concerning. Some estimates say that the ratio is around 1 doctor per 10,000 patients, and when you share an anecdote of that nature, it kind of sheds light on that. This number will vary from country to country and region to region, with some nations having greater shortages of medical staff than other countries. We also have rapidly growing young populations that exacerbate this disparity. But you've spoken to your choice of becoming a doctor, and you being your experiences with your mother early on that pushed you towards this field. But what kind of medicine are you formally trained in, and who were your role models that led you down that path as you were trying to become a doctor and pursue this degree, this field?
I think maybe globally medical schools are organized in the same way, where you have a first part which is the fundamental sciences, and then the second part which is the practicals in terms of getting into in-depth of clinical medicine, semiology, and being able to diagnose, treat, and prevent. In Cameroon, and I think in most African universities, we were formally trained in clinical medicine, and just to summarize, this included general medicine for adults, pediatric treatment for children, issues around obstetrics and gynecology, which are issues linked to pregnancy, labor, childbirth, surgery, all that is trauma and managing surgical complications, and of course some elements of public health, prevention, promotion, and health at community levels. These are the things that comprises the syllabus to make sure that we come out as matured and all-round doctors to be able to hit the ground running. And for me, my role models were specifically doctors in the rural mission hospitals in Cameroon, be it Catholic Hospital in Ginicom, where I spent all my holidays as a student, or the Presbyterian hospitals of Sac-Bayeme in Sanaga Maritime, or Enongal in the South Province of Cameroon. I worked in these two hospitals before moving to have a full job in Catholic Hospital Puma. And these are people who dedicate their lives to be able to work 24 on 24, 7 days on 7, to be able to take care of patients, and with kind of dedication, and they had at least the resources and the human resource to be able to do this under very tight and constrained fiscal space. So these were my role models, and that's what I dreamt of, and that's why I really worked hard to be able to do medicine, to become like them, delivering clinical care. Although, as I said before, I had to move on to be able to be on the discussion tables where we can look at the bigger picture, influence government policy, for example, to put more finances onto healthcare, and also to be able to make the right choices by investing in what is going to bring more dividends to the population.
And how would you compare the quality of African doctors and the training that they receive to, global medical talent? Not only based on the training that you received, but also when you compare it to, when you do comparative studies of healthcare systems and you meet with global colleagues, what's your analysis of the quality of our doctors?
Without any specific statistical analysis, I think from anecdotal observations, I think the trainings are the same, because the med schools have the same design and the syllabus should be the same. The difference is with the exposure. For example, when we went to med school, and myself in particular, spending my holidays in hospitals, jammed to capacity with patients of all types of pathologies, you get more exposure. And there are some pathologies that maybe in the Western world, they will read them only in books and will be very difficult to be able to really see these cases. While in Africa, you don't only read them, but you practice them. I remember working in the Catholic Hospital Puma, which is on the highway between Yaoundé and Douala. I did many things in terms of providing surgical care to patients. I did what we call splenectomies, which is actually taking out the spleen, which can get ruptured during a road traffic accident. And the only thing you can do is to get inside and get this spleen out, making sure that you don't hit the pancreas. It's a bit technical, but just for people who understand technical what I'm saying. So these are the specificities, but fundamentally it's the same. And I think I have many colleagues who trained in Africa and Cameroon, and they're excelling in the best clinical practices overseas in Europe and in the Americas.
That's interesting. So I think, maybe there's an argument to be made that African doctors, due to the volume of patients that they receive and the complexity of the diseases that they get a chance to interact with, and the challenges, the medical challenges that they have to find solutions to, I think there's an argument to be made that these doctors are actually better trained than other doctors in healthcare systems that may be more established and might not be facing as many challenges.
Well, I don't
how
want to
should
bet on the training, Maurice. I just want to say, at least, I guess the knowledge churned out to the students might be the same, but the exposure and the opportunities to practice what they learn might not be the same. Yeah, that's the difference.
Interesting. And so how should African governments address the challenge of developing local healthcare resources? And what are some of the most successful approaches that you have seen with the numerous healthcare systems on the continent, especially given that gap that we mentioned earlier of the ratio of medical doctors or healthcare professionals to patients?
I think, maybe I said it somewhere, but I just want to reiterate again. Governments in Africa should be able to make the right choices for their populations that would provide care as close to the population as possible. But at the same time, building resilience to shocks, which might be outbreaks or natural disasters. Simply put, they have to invest in primary health care. And this issue has been discussed many times in different international platforms. The 1979 Alma Ata Declaration asked African countries to invest in primary health care, and the definition and package of what we call primary health care is clear, but these people don't walk the talk. There were follow-up discussions in Astana to ensure that primary health care also includes community-based primary health care. And it is the best way to build resilience, because having the community being part of their healthcare provision, having community health workers being trained, deployed, and they are able to intervene rapidly when issues arise, I think that is the right thing to do, and governments should be able to kind of take that forward instead of building tertiary hospitals, which may be necessary, but will not be able to serve a bigger part of the population because they live in rural areas, they live in urban slums, they are poor, or they are even living in conflict-affected zones. So you have to design a healthcare system that is adapted to the continent, and also a healthcare system that is more on prevention and promotion rather than waiting to be able to cure. We always say prevention is better than cure, it's more cost effective, and I think that's what government should be able to take forward.
That's interesting, and I think this is more of an intimate perspective that I have. But, being a doctor, and particularly being the first doctor in your family, and coming from rural Cameroon, one of my childhood memories with you is going to the village. And, as a child, going to the village is never a a fun experience, especially if you're coming from, Africa's urban centers. Going to the rural centers when you're not raised there is always is always an experience, to say the least. But I remember going to the village, and us going to the village rather often. And whenever we'd be in the village, we'd sit in the house, in the compound, and other villagers, relatives of ours, would line up and come to see you, particularly for healthcare checkups. It's something that I found very, I wouldn't say strange, because we know, in Cameroon, African countries, when you're a doctor, say doctor, the doctors, there's a very serious respect that comes with that. So I understood what was happening, but I cannot imagine what that experience was like for you to, go through that training and then to go back to your home village, to your home, and essentially have all this demand for healthcare services from your relatives. So can you maybe speak to that experience of, going home just to see your parents, to see family, and then having to set time aside to, maybe an hour, maybe 2 hours to have, women, children come and get healthcare checkups from you. And I think speaking to that will also speak to some of the gaps that we have in our healthcare system. For you to be off duty, to be on holiday, but while you're on holiday, because the demands of our healthcare systems are so great, even while you're in rest and retrieve, you still have to provide those services that are, in very high demand. So can you maybe speak to your experience there?
Thank you, Maurice, for taking me back to these fond memories. I think these are some of the things I cannot forget in my early years as a young medical doctor out of school, making my mother proud of having realized the dreams she had wished me to have. And I did that with lots of pleasure. It was with great pleasure that I was able to kind of give back to the community. I was able to go home, and instead of resting, I could talk to all the people and discuss all the intimate issues, which is nothing less than their health. However, I don't think that was sustainable. Number one, I went home very few times, and I stayed for a very short time. And I just want to draw back what I said before. This is a sign of a lack of basic social services and inadequate investment on the side of government on primary health care. And I just want to reiterate again that providing basic social services to the community across Africa is a duty of governments as duty bearers. And it is the responsibility of the community as claim holders to hold government accountable for the provision of these services. There is no way out. And I think, I don't think this is much better than what happened in my early years, but we have to continue with this advocacy, because that's the best thing to do, and that is the right thing to do.
That's interesting. And, moving on to the beginning of your international career, let's put it that way. I think there's a lot of insights that you can share from just Africa's global healthcare system in its globality. So you graduate from medical school in Yaoundé. You work for 2 years at a Protestant and Catholic hospital in Puma and Ebolowa, after which you start your international career. So Puma and Ebolowa, for those listening, are cities or towns in Cameroon, rather. And you start your international career in a rather precarious situation. At the age of 30, in 1996, you leave Cameroon for the very first time. And the first place that you go to after leaving Cameroon is in Rwanda. And this is shortly after the Rwandan genocide and the Rwandan civil war, and at the very beginning of the Congo, the first Congo war. For our listeners, this is not going to be the focus of our interview, but I will say that, the first and second Congo wars are the largest conflict known to humanity after the Second World War. They're very interesting, pieces of history, contemporary African history to study. And it's important that our young listeners are also aware of kind of some of those challenges that we face. But Dr. Ngwakum, in your own context, you left Cameroon for the first time. You're going there as a healthcare provider, as a doctor, all right? So can you please speak to leaving your home country for the first time, and can you describe Rwanda in those days from the perspective of a medical doctor?
Thank you very much. This is a very passionate piece of my history that I talk with it with a lot of passion, and it was an adventure actually. Moving from the wards of the Protestant hospital in Nongal through the wards and the operating theaters of the Catholic hospital in Puma onto a Sabina flight to Belgium for orientation to be able to go to Rwanda to serve with MSF was a big adventure. And I just want to pause here to say it wasn't a choice. My choice was to be able to deliver for women and children in the best of my ability wherever I could find them, be it home in Cameroon or anywhere on earth. And that's why after school I worked in these Protestant hospitals of Sakbayeme, of Enongal, that is in Ebolva, and also I was a medical officer in Catholic Hospital Puma. But going back to why and how I left, when I was in Enongal, I met a friend, a very good friend of mine now, an MSF surgeon who came on visit called Dr. Morris, and he was very impressed with my job, young from school, 20 surgeons in one, they called us in those days because we could do every surgery. And there were no specialists in all the fields, and we had to do it because in any case, the patients were there and they needed help, from issues linked to delivery, to fractures from accidents, to opening abdomens to explore causes of infection. And based on this job I did, Maurice invited me over to Chad where he was working, which was in Bongo. And while in Bongo, he asked me to provide my CV. I told him I don't have a CV. And he gave me a piece of paper to write down, where did you go to school, and what have you done since you left school? And I gave it the paper. I didn't know Maurice had to send this to N'Djamena, to the head of mission, to invite me to come and work in Chad. And when I went back, I got this mail from the post office, offer of employment to go work as a medical doctor in one of the districts in Chad. At the time, Chad had less than 100 doctors actually, and it was a privilege to bring in expatriate doctors to help in this country. But I wasn't ready, actually. I wasn't ready because of two things. In my head, I thought I needed to work harder and get more experience before I go international. Number two, I had my fiancée, my beautiful wife today. We were not yet married, and I thought I didn't want to leave her behind. And I went to N'Djamena to excuse myself, and they were so surprised to see someone who came all the way. And they gave me contacts in Brussels, which is the headquarters of MSF, and told me, any day you are available, send a message to Human Resources. I got married, and I discussed with my wife, and we agreed, you may go. So I wrote back to them and said, I'm now technically and psychologically ready to go back to Chad at the time.
And like you said, Chad at the time had less than 100 doctors. This is in the 90s. in 96.
Correct.
Wow.
Correct. So what happened is there was change of a proposal because they needed me urgently in the hospital of Kabaya. This is in Rwanda. So I got a letter saying, please, you are going to come for your training for first departure, but no more chat is going to be Kabaya in Rwanda.
Mm-hmm.
And I thought I wasn't ready to go because we were expecting a baby, and I told my wife, I don't think I need to go. And she said, please write it nicely and tell them why. So I wrote, I sent it by fax, and I got a reply, 2 lines. 1, congrats for getting married. 2, congrats for the baby that is coming. 3, go to the embassy in Yaoundé and get your visa. Everything is ready, which I did. And they gave it very fast because MSF is a very well-respected organization. And within one day, one morning, I got everything. And I flew off to Brussels. I just want to stop here to tell you some of the experiences I got on my first arrival in Europe. Since it was too fast, the process, when I landed in Zaventem, which is the airport in Brussels, at 5 a.m. That Monday morning, I went to the immigration and showed my visa, and they couldn't find my name in the list of people that are having visas, and they couldn't link this visa to any embassy. I don't know what happened. The embassy didn't send this information to the Minister of Interior. So I was wheeled into a room, and I just want to say what I saw there is something that really kind of marked me. There were many people from Asia, from Africa, from mostly West Africa, that were locked up in this room because they didn't have the right papers to come to Europe. And I was one of them. But in reality, I had the right papers. I just needed to be able to call.
And this was your first... And this was your very first time in Europe, actually. Your first time you show your visa.
Time out of my country into Europe. And the MSF office could only open at 9 a.m. So I couldn't call. Between 5 to 9, I was locked up in this place. And I called a few friends, and which said just be patient when the offices will be open. And when the offices open, of course, they called the embassy, and I was released.
And did you have a chance to speak to the others that were, the other Africans, the other immigrants that were?
I did. Some of them were from West Africa, and we could speak in Pidgin, but everyone had specific stories. Some said they've been invited to go to maybe Germany to play football, but they're having a Schengen visa. I don't know. To be very honest, I had my own issues I had to solve, but then, of course, I was very positive. I knew I did nothing that was abnormal. I was invited. They gave me a visa, and so I was cleared, and I left. And I finished from Brussels, and I flew into Kigali and to Kabaya, where I spent over 6 months in this hospital village with 100 beds and a series of health centers that were around this hospital with a very vulnerable population. And I think this was just a few years post genocide, and there were still many things happening in Rwanda. There were a lot of destruction, not physical destruction, but human resources, with many people left with lots of mental health issues. Violence had actually reduced, but not completely stopped. In the hospital, in addition to women with challenges due to childbirth, we had children with malnutrition, malaria, pneumonia, diarrhea. But I still received some patients that came with bullet and machete wounds to the hospital. And what we did was we created kind of a referral system where people in the villages can track or can trek to certain health centers. I remember in Muramba and in Ramba, and then they could call us by radio, and we sent the ambulance to go bring them. So we were operational 24/7 on 7. It was very exciting. period, and I think it fitted exactly with my childhood dream of working within the healthcare system and in a hospital, providing the services I did at the time.
That's very interesting, and it's remarkable to hear your positive take on this. Certainly exciting experience, but also very challenging context for you to navigate, especially as a healthcare professional, as a doctor that is, at the forefront of a lot of the trauma that's being experienced by, the most vulnerable in that area. I think one of the things that's also interesting about this experience of yours, as I was, reading and preparing for this conversation, in 1996, when you were posted in Rwanda, it aligns with, the beginning of the very first Congo War. And so in 1996, as, you have a mass of refugees in 1996 moving back from Eastern Congo into Rwanda. All right, so refugees that were pushed out of Rwanda during the Rwandan Civil War are now being pushed back into Rwanda as Kabila's forces move from Eastern Congo to Western Congo at the very beginning of the war. And, in the beginning of this crisis of these, military generals are moving into the Congo, refugees that are being dispersed, you have what some estimate to be about 700,000 refugees. And these are some official estimates by different NGOs and international organizations. And as this mass of approximately 700,000 refugees are being pushed back into Rwanda, you just so happen to be there as a doctor for Doctors Without Borders, Médecins Sans Frontières at the time. Can you speak to some of what you saw? Can you describe this scenario as a doctor, as a professional, as a human, and as an African? What was it like to be there during some of the most challenging times in our history, our collective history as Africans?
I think, by the way, thank you for this question. And again, it's a very passionate episode of my life. And I don't think any description can make you visualize what I saw in Gisenyi that time in Rwanda. I think it was a Friday evening, and I was very tired. And we were authorized by our top management in Kigali to go to Gisenyi for a break. And on my way, my medical coordinator at the time from Kigali called me on the radio and requested me to go to the Petite Barrière. Petite Barrière, for those who know Gisenyi and Goma, is the border area between Rwanda and the Congo, or Goma city on the other side. I was dumbfounded with what I saw, a sea of people flowing with children tied on their backs, some of them already dead because of diarrhea and their dehydration. Everything that people can have was carried, bicycles, cattle, everything you can think of was flowing back into Rwanda. And for 2 days, I had to manage what we called at the time a way station hospital, which was just a stop point where we provided a first aid and some high energy biscuits or oral rehydration liquids for children with diarrhea. But the good thing, which I think was a good thing, is the government at the time refused to have a permanent camps again, and all the people were requested to go to their villages and to their homes. And so we could kind of link them for further treatment or services via the existing hospitals. So that is what I saw, if you want to understand exactly what happened at that time. And as you did say, is a time when the rebels, you may want to call them in quotes, were moving up to Kinshasa to get out Mobutu, who was the president of the then Zaire, which is the Democratic Republic of Congo, actually. But many other things happened after, and there was a lot of insecurity. And I remember in a paper I wrote, which I called Black Saturday in Kabaya, that Saturday, which was some Saturday in February 97, I guess, if I remember well. We had finished doing an operation on a woman who was having difficult deliveries, and we were very tired. And with one of the colleagues, we said, let's go behind our house and just go around and take some, I don't know, relax. But all of a sudden, as if from nowhere, we had like gunmen with Kalashnikovs and rows of cartridges around their necks that surrounded us. And I thought that was the end of it. And I said, okay, I thought about my wife, thought about my daughter, and I said, okay, I'm praying they should shoot, but they shouldn't hit my head, they shouldn't hit my thorax, they shouldn't hit my abdomen. I was ready for them to hit any of the limbs, the arm, the leg, so they can amputate our live. But as heaven could not have it, we were not killed, we were not touched. But they attacked this hospital village. They ransacked our pharmacy, drugs were looted. So many things happened. The next day, I came back to hospital actually, and we had so many patients and so many wounded people that came back. And I thought that was time for me to stay more than ever before. But when you are in such situations, you don't see beyond your nostrils. You just see yourself and the Hippocrates' oath to take care of patients. You don't even see the danger. And I thought I was the last to leave, and I didn't want to go. But I got orders from Kigali to come over to Kigali. And I remember my head of mission, Muriel, shout out to you, Muriel, if you one day listen to this podcast. She gave me the best advice of my life. She called me on the phone when I was already in Kigali and told me, if you die in a decade, everybody will forget, but your wife and your little girl will never forget. So think about them. And it was when I realized how much danger we were in. And I think, well, we got out of it. But just as we say, most of the humanitarians working out there, they're sacrificing a lot. And I think, and that's why I did say they are my heroes, because it's not easy to be able to provide services to people in these situations of insecurity where you can pay with your own very life in the course of providing these services. Yeah.
Wow, what a fascinating journey. I guess moving on to so some other experiences. This is the first of many experiences that you've had working in challenging circumstances. While working with Doctors Without Borders, you subsequently worked in Haiti, in Burkina Faso, in the Gambia, in Chad, in Mali. Can you speak to your experiences there as well? What exactly did your work consist of, and what did you learn about the African healthcare systems and emergencies, especially through these experiences?
Well, I think it was mostly providing healthcare to people, as I said, in hard-to-reach and remote communities. Also responding to public health emergency, for example, meningitis outbreaks in multiple countries along the meningitis belt of Burkina Faso, the Gambia. But something people may not know is MSF at the time also had structural or development projects in Chad where we designed and set up operational districts and having community engagement, put in cost recovery mechanisms. But from all these experiences, be it with MSF or other agencies, my take-home message is African governments need to make the right choices for their populations by investing in basic social services that will build resilience and even bring peace and tranquility. Most of the crises are linked to lack of basic social services. Including illegal immigration is due to lack of basic social services. And this is what brings social unrest in most countries in Africa. If governments can invest and make sure that put resources to be able to provide basic social services healthcare, water, sanitation and hygiene, education system to the population, I think most of the crises must have been prevented or even averted.
Wow. And, now moving away from, the emergency situations that you saw and you experienced, and moving more closely to your experience with the United Nations and away from your experience with Doctors Without Borders, you start your now nearing 20 years career with the United Nations Children Fund in South Sudan, but this was in the early 2000s, prior to South Sudan becoming a nation. At the time, you were working in what was known as Sudan proper. Can you speak to this experience of yours, your first experience with the United Nations, and what that entailed of?
Well, I think it's straightforward. My experience in South Sudan, although was with UNICEF and not with the NGO MSF, was kind of a continuation of the job I did with MSF using a different platform. Simply, we supported government to provide healthcare to people in hard-to-reach areas and bringing in interventions to help narrow the equity gap, responding to outbreaks, for example, the case of meningitis in in 2006, actually. So it's just a continuation, if you want me to stay on this segment of Sudan and South Sudan. Yeah.
And what were some of the things that you saw there at the time? In those days especially, like, can you describe Can you describe some of the experiences that marked you in Sudan in those days?
I think actually was a garrison town, they call it in those days. It was actually linked to Khartoum and wasn't really South Sudan administratively until when the divide came, when became South Sudan. But it was in the same line with other health systems in Africa, marred by weak systems, whereby you don't have a proper governance and policy environment to be able to operate. You have issues linked to human resources, number, quantity, and distribution. You have issues linked to healthcare financing, where you have insufficient funds and also not adequately distributed for the services that people needed. So I think it's not very specific, but these were the big things that we had to deal with in WOW. And what we did was trying to ensure that we provide services that are going to cross certain lines. And I think other challenges we had was some of the villages in WOW were at the time, although WOW City was under Khartoum, there were other rural parts that were under the SPLA, which was the military wing that was fighting for independence of South Sudan. And to get to those areas, we had to ask for permission from the military leaders to be able to let us and make sure that we had the protection. So those were the specificities of WOW beyond the systems that were weak as everywhere.
Of the many roles and titles you have held during your time at UNICEF, some of the recurring areas of specialization in each of your roles are immunization, nutrition, maternal, and child health. As we know, children are the future, and African youth are certainly the future of the continent. From your perspective, you have a very intimate relationship or perspective on, rather, shall I say, with Africa's mothers and Africa's children that you've worked very closely with over the past 2 decades. Can you speak to Africa's children, to Africa's mothers? Can you speak to the malnutrition that we see and what that entails? I think a lot of people from the diaspora and looking at the continent from the outside, or even, even within the continent, if you're coming from more urban areas and you're not as exposed to rural areas, you see pictures of, children with large bellies, with flies, in some of the most vulnerable areas of the continent, and you having a front row seat and working to strengthen those systems. Can you tell us more about Africa's mothers, African children's, and the fight against malnutrition in particular on the continent?
Well, those are important discussions, actually, and I may want to cite some of the reports that we are having. The recent UN report, 4.4, a young person or a child dies every 4.4 seconds. Another staggering revelation is that globally we're having 5 million children who die before the age of 5 in 2021. And if you drill this to Africa, in sub-Saharan Africa, we are contributing to 29% of live births globally. But we are responsible for 54% of deaths. Not acceptable. And I think all this is linked. Underlying cause of deaths among children under 5 is malnutrition. But malnutrition has other determining factors which are linked to other deprivations. In general, in Africa, primary health care still is not taken to scale. Despite the inputs over the years, challenges still remain because many women and children still die, as I told you in the figures before. And these deaths are due to preventable causes that are linked to weak systems, poor investment in primary health care, gaps in immunization, and some children leaving children behind, actually. And these are especially in the geographically hard-to-reach areas. You may talk about the urban slums, the countries in crisis, and having kind of insecurity. All these populations are the people that we have to ensure that they are not completely left behind. And this is exacerbated by other natural disasters. You remember, I don't know whether you know about the drought in the Horn of Africa affecting 3 countries, Somalia, Kenya, and Ethiopia. And in Southern Africa, we got floods, Cyclone Freddy, that came in and destroyed many health facilities, including education facilities, some of the Southern African countries. And we have a great comeback of cholera, which are some of the things that contribute. But I just want to say healthcare alone cannot solve the problems. We need interventions that are going to fight poverty, social protection, because that is the baseline. When you're poor, you're exempted from many things. Things like early marriage. A girl that gets married at 14 gets pregnant and has complications that are linked to her own self because she's not yet matured, and she delivers a baby that starts with problems, and those are issues we have to be able to address, including what you said before, nutrition. But availability of water and sanitation is also very important, right? Because if you don't have water, what happens? You get diarrhea, what happens? You send out all the nutrients that you have, and you exacerbate the malnutrition that is already on the line. So I just want to end by saying Africa needs whole of government and whole of society approach to be able to deliver basic social services, especially healthcare.
So, you shared some staggering statistics on the challenges that we're still facing. Can you tell us about some of the progress that you've seen in your field throughout your career and some of your most proud accomplishments in terms of progress that we've seen in our healthcare systems? Because I think despite the the ground that still needs to be covered and the improvements that we need to have in our healthcare systems. You've been in this field for over 20 years at this stage. So how has it evolved, and what are some achievements that you yourself and your colleagues have been able to make to improve healthcare systems?
Well, I think many things have happened. We have to count our blessings as well, despite the fact that we want to work hard to even deliver better. There has been progress in many aspects. For example, vaccination coverage has increased globally, reducing the number of vaccine-preventable disease outbreaks. Although in the last decade there has been stagnation, reaching some of the children, and even what we call backslide due to challenges that were faced with the COVID-19 pandemic that brought in other challenges and hindering people from having access to healthcare. But overall, there has been some progress, even in reduction in mortalities and improvement in number of women that get skilled attendant at birth. That has increased. But we have set goals, SDG goals. We want to be at 12 newborn deaths for 1,000 live births. We want to be at, I guess, 25 under 5 deaths for 1,000 live births, and we want to be at 70 maternal deaths for 100,000 live births. Many countries will not be able to attain these targets, although there are some improvements. That's why I keep on saying we have to keep working hard and coordinating with governments to be able to vaccinate every child everywhere. That's the bottom line. We have to continue working with governments to make sure that they spend more money and they spend it better, making sure that there are operational and allocative efficiencies, putting this money where we are going to have more dividend. For example, ensuring that the children are vaccinated. We have to continue working with communities to strengthen demand and confidence in healthcare delivery, including vaccination, because there are so many objectors because of religious reasons, objectors because of cultural reasons, and other reasons that we need to contextualize and make sure that we find kind of solutions to this. And above all, we need to build resilient systems. From the experience we got from COVID, weak health systems are quickly eroded in the face of challenges, be it natural disasters, be it public health emergencies or vaccine-preventable disease outbreaks. So government should have to make sure that they build systems which is investing in primary healthcare, as I've repeated, ensuring that community-based primary healthcare is taken to scale, and this is going to help us to be able to resist some of the shocks that come with difficult situations. Yeah.
And can you give a concrete example of how an already weak healthcare system is faced with a crisis and is completely eroded to the point where you almost have to rebuild the system from scratch? Are there any case studies or examples that you've seen in your?
I already told you about what happened with immunization. For 10 years in the African region, we had a stagnation. We were not moving. We were not dropping, we were not moving. We stand around 79–80% coverage because we had issues. Financing was not going up. Human resources was not going up. Coordination and type of policy framework had loopholes. These are weak systems. Now, when COVID came, for example, in Eastern and Southern Africa, where I'm kind of focused for now, we lose 6 percentage points between 2019 and 2021 in coverage. That is an erosion.
Wow.
But if the system was resilient, we wouldn't have had that shock and that backslide, which means more children are left out of the immunization coverage. More children are exposed to be able to have outbreaks, because outbreaks happen because you have a back pile of children who are not immunized, and when the germ comes in, then you have an explosion of the disease. Yeah.
And when you gather immunization data, is it specific to different diseases, or this backslide that you're referring to, is it a general immunization statistic, or is it specific to particular outbreaks?
No, it's for all the diseases actually. But we have indicators, and we take one of them, the DPT3, to be able to assess and say if we already have reduction in this amount, all the other ones are affected, because they are all linked.
Wow. And, one of the things that I am hoping we can speak to now is focused on, the financing of public health systems and building our own independent systems on the continent, right? So I think now we're living in a particularly tumultuous time in African history. Naturally, we're very young countries, only about 60 years, give or take, from independence. We have a very young population, and there's ongoing reflections on development models, governance structures, and essentially determining what's the best way to bring prosperity to Africans, regardless of where they are and regardless of their background and context, right? And within this ongoing context and the range of different issues that different countries and regions are facing, one of the things that's being put into question is how do we coordinate development partners that come from various regions of the world, and how do we strengthen our own structures and policies to bring forward development in our own countries. All right. So you've worked in a range of different countries with a range of different governments. You've worked with a variety of NGOs, development partners, and within your current role, you're mandated to kind of coordinate the efforts of government and other development partners in the entire East and Southern African region. A lot of the work that you guys do is aligned with advancing the UN Sustainable Development Goals. Can you speak to this ecosystem of development partners and how they work together to build African countries, particularly their healthcare systems, and maybe some gaps in the way these partnerships and structures, and some opportunities that you may see to strengthen these partnerships to be able to deliver more value for Africans at large, and obviously within the context of healthcare. Maybe you can speak to that.
Yeah, I think this is a very interesting topic actually. And aid is good if it is put in the right place and the right context. And I always say, for the health sector, resources should be able to support the implementation of government-led strategic plans, national health strategies, where government has come out with what they need to do, what are the resources they have, and partners can come in to support them to fill gaps. But with partners coming with already predefined agendas, I think this is not helping. It's going to kind of add resources that are not contributing to the national goals and may not deliver the results that the governments are aspiring for. That's one. The second observation, in as much as foreign aid is good, I think this is not something new. Foreign aid, or what we call overseas development assistance, ODA, is not predictable and it is not sustainable. For example, with what is happening in Ukraine, many things have happened, and if governments were counting on foreign aid to be able to support their health systems, you wouldn't get as much as you had predicted for, because there are other compelling priorities for the persons that are calling themselves the donors.
Can you actually, that's good.
Yeah. Now, what I'm saying is African governments, they should make the right choices by investing in basic social services, including healthcare delivery. For example, there has been meetings and agreements followed by declarations, such as what we call the Abuja Declaration, where governments, heads of states of Africa, agreed to put 15% of government budgets into healthcare delivery. This is not being done. By many countries, they don't. And even with the little money they put, there are other challenges, what I may call operational and allocative inefficiencies. They don't put the money for the right place, and they don't use the money correctly. The little that is allocated most of the time is for salaries with little resources to support implementation of activities. So these are the issues that governments across the board in Africa should be able to address if they really mean to bring peace and tranquility among their populations. To be able to stop illegal migration, they have to ensure that the population is confident that they're going to have basic social services.
Very interesting. So on one end, with the challenges that we're facing, African governments are not meeting their commitment to contribute a certain percentage of national budget to strengthen healthcare systems. Now, even with the budgets that are allocated, you have, they're misallocated in terms of where the financing is being invested. You may have, financing being invested in a particular segment of the healthcare system that is not the most vulnerable or where the money needs to be most demanded. And then even with the misallocation, in terms of the way that it's operationalized, there are also other gaps in terms of its operationalization that limits the effectiveness of this financing. So there's a lot of work. Ultimately, there's a lot of work for African governments to do to ensure that these frameworks are structured in a way to better serve Africa's patients. But I'm curious to know also, one of the things that you mentioned was the unsustainability of foreign financing and foreign aid. Right. So I think, we're young countries. Naturally, this is a big part of our national budgets in this day and age. However, if we're thinking about growing our countries in the long term, it cannot be the focus of our development strategies. And then you mentioned, the unpredictability of this financing. And I think that's where I actually would like you to elaborate more on. So can you speak to this unpredictability? What does it actually look like? How are these African healthcare systems financed? And why is this? You spoke to Ukraine, you know what I mean? But, there's other cases where financing is certainly diverted. But what does it actually look like for a minister, an African healthcare minister, to deal with this fluctuating budget? Maybe you can speak to what you've seen on the field.
Well, thank you very much. As I said, if you go by proportion of money put by foreign aid and money from domestic resources, it ranges from 40% to sometimes 60% and beyond of government health budgets in some countries catered for by foreign aid. And like I said, it's not sustainable because once you have a situation where there are competing priorities at the international level, this money can drop very, very seriously. Number two is for this support to be efficient, the mechanism of channeling it to the country has also to be thought through, and it has to be based on local need, not on priorities set outside the country and copy-paste onto the country. It sometimes doesn't fit, and it might lead to inefficient use of resources. So those are things that, and this is all about governance and government leadership. But as I said, the most sustainable and effective way of financing your problems or your system is by domestic funding. And this is an appeal to governments across Africa to make sure that they make the right choices for their populations, and they make sure that the investments are skewed towards investing in social services, basic social service, and in the case of healthcare delivery, primary healthcare. There are times when, even when the money is available, the allocation is linked to political situations whereby there's an election coming and they want to hurriedly build a health center where they don't even need it, just to be use it as a token or a chip to be able to buy votes. That is possible. Wow. And I think these are some of the things that we have to dissociate politics and provision of basic social services for the population, which at the end of the day contributes to give to the votes that maybe the politicians may need, and also contribute to be able to bring resilience, and services to the population. It's just a matter of making the right choices, not convenient choices.
Wow. Yeah, I mean, I think it's that's a statistic I was not familiar with. That, you know, in some countries, up to 60% of the national healthcare budget is financed by external benefactors, and that can, like you mentioned, that can actually vary drastically. Have you ever been in a situation where from one year to the other the national healthcare budget has dropped by a drastic amount due to this fluctuation, and if so, how has government reacted when these things happen?
Well, I think it's very current to see aid stopping immediately, and most of the time there are always these sustainability clause into some of the grants that are being given, but most of the time in some of the instances it's very difficult to be able to mobilize these domestic resources to be able to cover, and that's why we don't have sustainable results. You have improvement in coverage, and a year down the line, because of resources not being adequate, you have reduction in this coverage. So it happens all the time. But bottom line, I just want to repeat one more time, is governments have to make the right choices for their populations in Africa. And that right choice is investing in basic social services in their policy framework, as well as accompany this policy framework with the required resources. And there are many ways of doing that. It by looking through the different line ministries and say, for example, is it better to invest in the Ministry of Defense or in the Ministry of Health? And how can this investment in the Ministry of Health improve security, social coherence, and improve the lives of the population? These are conversations governments need to have and make the right choices.
Wow. That's very interesting. I like the way that you framed it, in the sense that, you know, governments, you know, all of these different challenges that are driven by a range of different factors that we see, that results in fluctuating, you know, advances in our healthcare indicators on the continent, fluctuating results. You know, all of these can be addressed by, you know, having these healthcare systems more independent, which can only happen through the investment of governments, and not only over a short period of time for political means or for getting votes where the funds might even be misallocated, but really a long-term strategy to invest in our healthcare systems for the betterment of citizens. And I'm curious to know, for yourself, you know, in a world where African leadership is investing in its healthcare systems for the benefit of citizens, you know, what would the future of development organizations on the continent look like? What is your take on the role of development organizations, particularly in healthcare, as it is today and as it will look like in the next 10, 20 years or so? What are your thoughts on how these organizations will continue to evolve and that relationship with the continent will move into?
Well, I think that is another very important question, Maurice, and thank you for that. When you were talking, I was thinking, and I think in reply to that, there is a future for productive partnerships, but it has to be adapted to solve local problems. Local problem means problems that are perceived by the local population, by the people that are receiving these services. I think this is the only way to win ownership and participation, as well as a win-win collaboration. Projects that are designed outside the community are bound to fail. Because this is going to be short of identifying the real problems that the people need, and for which they need help and for which they don't need help. So dialogue, coordination, collaboration, and listening to the people that are on the receiving end to know exactly what they need, I think that is the key future to continue a win-win partnership and collaboration moving forward.
Wow. And I guess moving on, you spoke to immunization before and sentiments towards vaccinations due to religious beliefs, cultural beliefs, things of that nature. I'm hoping that we can actually, speak to something that's very top of mind in global health circles and in just the world generally speaking, and that's the COVID-19 epidemic that we just lived through and that we're still working through, I would say, depending on where you are in the world. At the beginning of the COVID-19 pandemic, every media channel in the world warned about how COVID-19 would devastate the continent. You turn on any news channel and you'd see reporters, as bad as things were, as cases would rise in the Western world, in the Eastern world, the focus at the very beginning of the pandemic was how Africa would remain devastated. And now fast forward, past the pandemic, with the most dark times of the pandemic, at least it appears as though we weren't as negatively affected as it was predicted. Can you speak to maybe why that was and what Africa experienced during this COVID-19 pandemic?
I think there are many theories which need to be validated. Number one, I think there's a demographic factor where you say they had more cases and where COVID were more devastating. They have a different demography from Africa, and the people who are considered to be the at-risk groups are the people that are the older people, and in Africa we have fewer older people because of our demography and our life expectancy. So that's number one. The second one is linked to, again, lifestyles and other underlying factors like other chronic diseases. And I think we do have people with chronic disease in Africa, but maybe not as much as in the other side of the world, where their living styles and their eatings render them more exposed to these diseases. But above all, maybe this is another guess which has to be validated, is the immunity factor, where because many young people got infected, we maybe had a quick herd immunity where people already got inoculated because of the infection itself. But I just want to profit to say, at the beginning of this pandemic, we had issues of availability of vaccines, and if at all the pandemic was as hard in the richer countries as in Africa, it would have been a catastrophe. But unfortunately, or fortunately for Africa, as I said, some of the few reasons that I exposed, we didn't have that. Vaccines were not available for us. But when these vaccines became more and more available, we had other issues. Government needed money to be able to procure the vaccines, although there were some donations. Government needed money to be able to take the vaccines to where they are. And we have this issue of objectors and people who refuse vaccination needing resources to be able to give them context, specific orientation for social behavior change. So I think those are some of the elements and the dynamics that occurred during the COVID pandemic. Yeah.
I mean, I was just about to get to that point. I'm happy that you started speaking to it in terms of the procurement of vaccines and the challenges that African governments faced. The COVID-19 was a very challenging period for anywhere you were in the world. There was a lot of uncertainty, and the pandemic itself was very politicized. I remember that. Even the procurement of vaccines, depending on where you got the vaccine from, whether it was an American or a Western vaccine, a Pfizer or Moderna, whether it was a Russian vaccine, a Chinese vaccine, all of these were heavily politicized. The science was almost put aside. The point I was just about to get to is what you referred to earlier, and it's surrounded around the challenges that African governments faced in the procurement of vaccines. you know. And I'd spoken to, you know, some of the political realities at that time with all the uncertainty that was going on. You know, the science was almost put to the side, and the sourcing of these vaccines, whether they were coming from, you know, Western companies or from Eastern companies, right? So you have our Modernas or Pfizer's, and then you also have your Sinovacs, your Russian vaccine as well. And you know, where these vaccines were being sourced was heavily politicized. But beyond the politics, there was a heavy need by the populations. And you mentioned that the availability was a huge challenge. And if, you know, Africa maybe did not have the demographics that we have, there's a lot of, you know, substantiated claims around why we're able to navigate COVID the way that we did. And I think there's still a lot of research to be done to really bring the truth to light. However, if we had the same demographics and the same realities as other portions of the world, it would have been completely devastating. We would have seen something like never before. And I'm curious to know, when you speak to availability, can you speak to some of the complexities that African governments had to navigate early on during the pandemic in terms of sourcing vaccines and the challenges that they face with global partners to be able to get vaccines to their citizens in the most vulnerable places on the continent and in the world?
Yeah, but I think there were multiple sources of these vaccines, and governments had to make a choice on which of the vaccines coming from the different countries. Many governments took all the vaccines, no matter the choice of the vaccines that were provided through some of the aid platforms. Some governments, like Zimbabwe, remained with the vaccines that they had registered first and requested all other aid to be used for procurement of these vaccines that are registered for Zimbabwe. But again, as I said before, this is a governance issue. And government should be able to take the lead and make the right choices by investing in what will be the most efficient and profitable for their populations, including the type of vaccines, because these vaccines had linkages to cold chain, and you have to make sure that the vaccines you're bringing in are able to be stored correctly and deployed to the hard-to-reach areas on time. You had to make sure that you are assertive enough to be able to not take vaccines that are expiring in a very short lifespan, which you won't be able to deliver before they expire, and you have a symmetry of vaccines when your population is not vaccinated. So these are all some of the elements, but as I said, it all linked to governance and leadership by our different governments on the continent. Yeah.
And what would you say? You know, there's the role that our leadership on the continent has to play. But I remember during COVID, at the time, I was experiencing a big part of COVID in Canada, and I remember in Canada, the Canadian government had procured up to 2 times, if not 3 times, dare I say more, the vaccines required for the population, right? And when you compare that to some African countries that weren't even able to provide vaccines or procure vaccines to even, for 1 dose for the entire nation, it just shows the gross disparities in the vaccine sourcing. Are there lessons to be learned here by African governments in terms of how we will address these pandemics in future and navigate, or collaboration with international partners? And are there lessons to be learned by international partners as well in terms of how to work with, I guess, the less fortunate countries when it comes to procuring or developing the or ailments to these diseases that we face and these pandemics that we face?
Well, I think, as I said before, aid shouldn't be considered as something that is sustainable, and it can be very, very unpredictable. In terms of preparing for the next pandemics, number one, pandemics that can be prevented by vaccines can be challenging when you don't have the the vaccines in country or available on the continent. And I think this is something that Africa CDC is working on under what we call the new public health order, and trying to coordinate for possible production of vaccines on the continent. But I think, as I've always said when I have the opportunity to say this, there is need for thorough market analysis and demand intelligence to ensure these vaccines are competitive on the market, and we coordinate for this to be used efficiently for our populations. There has to be division of labor and proper coordination, because we cannot have every country with a few millions of people producing vaccines. It's not going to be cost effective. But I think, as I said, there are continental platforms and bodies that are looking into this, and I guess we'll be able to have a better approach for the next outbreak. But back to what I said, I guess by saying it over and over, it's going to be sink and become clear. Governments have to make the right choices. And the right choice is by investing in interventions that are going to build resilience. Resilience that will resist shocks, be it another pandemic or outbreak or natural disasters. And this is by investing in basic social services across the board, and for the case of our conversation, primary health care.
Absolutely. And, you know, there were a lot of different governments that stepped up and, you know, made claims of having developed local ailments to COVID vaccine. I think we're far enough from those early days of the pandemic to see that those ailments were not necessarily the most successful, to put it simply. But I'd like to know what efforts were made to develop local capacity to manufacture vaccines and ailments, and what were the obstacles to creating an African vaccine, not only for this pandemic, but for potential other pandemics that may come in future.
As I said, this is ongoing, and you need time to be able to mobilize the resources and convene the right technical expertise to be able to do that. And it's something that's going to be done as soon as possible under the leadership of Africa CDC. So as I said before, it's something that's ongoing, but I cautioned on proper market analysis as well as proper demand intelligence to make sure that once the product is on the market, it becomes kind of not only used, but at least brings back at least the resources that were used to manufacture this product, or else it's going to crash.
And can you elaborate on that? I think for a lot of people that are not familiar with healthcare systems, what does market analysis and demand intelligence mean within the context?
If you want, I can give an example. Many years ago, I was working in Mozambique, and it was decided to create a platform or a place to manufacture what they call plumpy nuts. A plumpy nut is ready-to-use therapeutic food, which is used for the treatment of malnutrition. Now, it didn't last for a couple of years. They had to close it up. You know why? The studies that were made were not in-depth enough to be able to determine where are you going to get the raw material, the peanuts that are being used. Do we have a local market that is going to make sure that we have all those peanuts? Number two, the production cost against the market. If you put in $1 million to produce and you have only $800,000 for buying, you're doing at a loss, and you will not be able to sustain this industry moving forward. And also, overseas, they have economies of scale. They produce these drugs or these therapeutic feeding, in the case of this industry in Mozambique, in a very large scale. And the more you produce, the more you reduce the unit cost. So these are the things that people, I think it is ongoing, but it has to be, because from my experience over the years, I have already a documented experience of something that failed. And if that is not, every country cannot decide to produce their own vaccine. It's going to fail. Who is going to buy for who?
Right.
So that is, using this example, I hope it is clearer. It is clearer for our audience on what I'm talking about, market economy analysis and demand intelligence. Who is going to buy, and if at all, the production costs can be covered by the selling costs and including profit for this to continue being produced in the future.
It's important, and it's so. This is, I guess, a bonus clip, and I think there's an interesting opportunity here for you to share something for the African youth, and that is what advice would you give to young aspiring African doctors? You know, there's a lot of there's a huge gap, as you've described throughout this interview, that we've been able to identify. But what advice would you have to a young doctor, a young child that's thinking about maybe pursuing a career in medical school? I'll say it myself, as an African child, I have failed you. I'm not a doctor. I think that ship has sailed. You know, like, who knows? I'm still young, so maybe I'll still make you guys proud. But like, it's not looking like it. But for the other good African children out there that would want to make that parents proud, but beyond just good African children, like, we have such a demand for these services. It really is. You mentioned Chad has had 100 doctors in the 90s. That's not very long ago. That's like 20 years or so ago, right? So what advice would you have for young aspiring African doctors that would like to contribute to strengthening our healthcare systems?
I have two things, Maurice, and you have so many doctors, but you have so few real doctors. And the first thing is you have to listen to your heart. And medicine sometimes is like a call, and you have to make sure that you really listen. Is this what I want to do? Or is this what somebody is pushing me to do? As I said, from my own experience, it's because of the wound that I had on my hand that pushed me to where I am doing today. So it came from within. And I had some obstacles on the way. When I was in Form 3, which is the third year in secondary school, my geography teacher came to class and said, guys, if you want to be rich, do petrochemical engineering and work in the oil industry, and you're going to be very happy. And I fell to it. I thought it was a mentor. And I said, okay, I'm going to do petrochemical engineering. Instantly, with a couple of friends, we were calling ourselves petrochemical engineers in the dormitory. And what happened is, based on that, I dropped physics and concentrated on geography. And when I went to high school, I did biology, chemistry, and geology, which will lead me into petrochemical engineering without knowing what I was thinking or to work where, I don't know. But when I was finishing high school, I thought I made a mistake. And I said, no, I have to go back to what I thought I wanted to do, which is medicine. But now I have a challenge, because for me to go to med school, I need to write a competitive exam in which there is physics. And this is the second point I want to come back onto the young people. No challenge is unsurmountable. And because I believed in myself, and because I read the book, The Power of Positive Thinking, it changed my life. And I said, everything is possible. There was a phrase there: if you create the stage with conditions of impossibility, it will be impossible. But if you think positive, even if it's difficult, it will be possible. I remembered, and I believed in it, and I worked like you cannot imagine. I auto-taught myself physics. I read 2 textbooks of more than 400, 500 pages, from the first page to the last page, like 3 times. And I passed. And because I...
One of 75.
Yes, I was one of 75 out of thousands. So but I was not a mainstream. I was biology, chemistry, geology. So in the predictions, I was not among the people who were predicted, who was even thought we could pass. But I passed because I had positive energy. So that is the second point. So I have 2 points. People aspiring to be doctors, number 1, listen to your inner self. Number 2, remember, no obstacle is insurmountable. When I went to med school, it wasn't easy. I had to study in French and English. 60-70% French and maybe 30-25% English. I remember I told you I had to come for second session. I think I said that somewhere, right? Because of my teacher. That is something that could have discouraged me forever, but I didn't. I came for the second session, I passed, and I continued. So it's a bit of resilience, it's a bit of inner self to make sure that you really want to do what you want to do.
Dr. Ngwakum, thank you so much for your insights. I think this has been an incredibly insightful conversation. Healthcare systems are at the backbone of our countries, of our communities, ensuring that the most vulnerable are provided for is at the heart of our economic success and at the heart of our development, the success of our children in schools, the success of our labor force in terms of generating economic value. So I think this has been an incredibly insightful conversation. As we approach the end of this interview, I'd like for you to speak to African unity, but within your context. So maybe if you had to construct a perfect Pan-African healthcare system, what would a continental healthcare system look like? And is a continental healthcare system even possible, despite the fragmentations that we have due to the different national boundaries that we have and that we know on the continent?
That's very important, and I think we are already working on kind of collaboration across countries because diseases have no boundaries. We had a meeting recently in Malawi to talk about cross-border transmission and management of the cholera outbreak that was raging this region of the world or of Africa. And I think, just to be very basic, there is a slogan which says unity is strength, and I think as a people with common challenges and aspirations, being united can only bring us dividends. And we have to focus more on what will unite us than what will divide us as Africa, and identify entry points. For example, in the case of healthcare delivery, if it's not ensuring coordination to be able to manage pandemics and public health emergencies linked to outbreaks, it is how to coordinate on local African production of vaccines and other supplies. And as I said before, with proper and candid and economic analysis and demand intelligence, that will solve the African problem in a sustainable way. Yeah.
Mm-hmm. Wow. And finally, any advice, a proverb, a book, or a music recommendation that you have for African youth today to help maybe inform our efforts towards building a more prosperous continent?
Well, I think if I use a proverb, there's an African proverb which says, when a child decides the mother will not sleep, the child will not also sleep, because you must stay awake to make sure that your mother is not sleeping. And I think interpreted, this simply means if we don't act and we don't act correctly, we're going to also bear the consequences of this inaction or the wrong actions. So I think as a continent, as young people, which you are, you have to coordinate across the board to be able to ensure that not only you work for a future which is going to make life more comfortable for you, but you're working for a future that you're going to leave for posterity, for the young people that will come after you and find a more agreeable or a more comfortable place to be able to live with the basic social services that are available, and where people can be happy on this continent with abundant sun, with abundant plenty. You plant anything, it grows in all seasons in Africa. And this is not only are going to avert us from being victims of public health emergencies or having all the eroded systems that cannot be resilient faced to natural disasters, or which is going to push the youth from wanting to cross the oceans to places that they don't even know, which they only imagine how beautiful it is, which in reality is not more beautiful than where we are living and where we can make it even better.
Absolutely. Thank you very much. Dr. Ngwakum, it has been an absolute pleasure having you here with us on the Project Umoja podcast. I think I did my best to stay on the professional line throughout the interview, but I have to say, as we close this has been an incredible experience, even for myself. I think I was very nervous coming to this, not sure what would come out of it. I really hope for our listeners that, a lot was learned. I know I certainly learned a lot. Some of these stories I've heard, but there's certain insights that were even new to me today. And I really have to say this, as we document this, I really hope that this is something that future generations will be able to look back to. And this is not only specific to this interview, but to any of the interviews that we've had in the past. I have to say this, Dr. Ngwakum, Daddy, you are our African hero. We love you. And I say this not only about you, but about all the healthcare professionals that make it possible for us to prosper on the continent. There's certainly, as you mentioned, there's certainly a lot of work and investment to be made in that space to ensure that all Africans, regardless of where they are or they may find themselves, are able to have access to basic services. But really, the work that you do is you are all the unsung heroes of the continent, and we really, on behalf of myself, on behalf of the Project Umoja team and African youth, wherever we may find ourselves, this is really a thank you for the incredible work that you guys do. With that being said, this is another episode of the Project Umoja podcast, and we'd like to thank you all for listening in. Looking forward to hearing you all and to having you all listen in on another episode of this podcast. Thank you very much.
Thank you.